All right. Hi. Good morning, everybody. Um, Celia introduced me briefly yesterday. My name is Jenny Bonner. I'm currently a scientist based at FHI 360. It's a nonprofit, but I was in academia a few years ago when I did my MRP. And so I'll be talking today about my MRP, about assessing and enhancing informed consent using a couple-based perspective. Um, mouse. All right. So the outline of my presentation, talk a little bit about autonomy and informed consent, then go into this concept of relational autonomy. I'll give you a summary of my MRP. I remember first days of RETI. It might be helpful, I hope, to see one that has been completed to give you some ideas, and then just in with some implications and final thoughts about like what I've learned and how I've carried this forward. Okay, so the importance of autonomy. This is an explanation from the common rule revisions that I find helpful and easy to understand. That informed consent serves several purposes, but an important one is letting people make their own decisions about what they really want and what best serves their interest. However, we know what best serves our interests are often impacted by and impacts those around us. That we're not these like autonomous agents in little individual bubbles who go about this world with no other concerns or cares about anyone else. And our decisions are made, we are socially embedded, and our decisions reflect that. So for example, my decision to come to RETI, yes, as an autonomous agent, I said I would love to come. But first I talked to my husband, I talked to my in-laws to make sure I had childcare covered, talked to my institution to make sure it was okay. This wasn't like me alone, adrift in the world. But often in research, we forget that. And we think of autonomy as person-centered, one individual, and we kind of forget the rest. And so this one paper by Osamar and Grady, if anyone is interested in this concept, I highly recommend it. This idea that relational autonomy seeks to balance notions of independent autonomous agency with the reality of social embeddedness. So it's recognizing that decisions that we don't make alone, and we make them thinking about what our decisions will mean for others. And this particular, sorry, the color's a little weird. This particular example comes from thinking about this in terms of couples, heterosexual couples, particularly in contexts where males have more power than females. And so if you look on the left-hand side, where we see the more autonomous, where you would just have a woman who's making decisions for herself, partner might not even be involved. And on the far right, we see that the man makes decisions for the woman without involving her. But there's a lot of gray in the middle. So we could have the man and the woman being equal partners, where they talk about health that impacts one another, they make decisions together. In the middle, we could have the man maybe influencing the woman more, but she's okay with that. She respects this and she doesn't feel disempowered. Or we could have a situation where the woman relies on the man to make the decision because he thinks he makes superior decisions, might be culturally embedded, and so on and so forth. So we have these two extremes, and then we have a lot of gray. And so part of my MRP was to figure out like, how can we incorporate that gray area to perhaps enhance autonomy? Why is this so important in HIV-related research? We know HIV transmission involves dyads. It's to sexual partners. It also involves parenteral transmission. This doesn't happen alone. Not, again, there's context and there are others involved. And that treatment for HIV helps with prevention. An unusual, I would say, scenario where we do have this U equals U treatment as prevention. My partner is not viremic, then I'm protected. And then we also have where prevention, if I want to prevent and protect myself, that often this requires dyadic coordination. This was more true back when we just had barriers like condoms, or somewhere during sex this had to be negotiated either implicitly or explicitly. You know, with PrEP, we can have more discretion, but partner involvement still important in some cases. And we know that research generally focuses on ethical principles as they relate to individuals, not dyads. So what happens in studies where both partners are potentially impacted, and could allowing for partner involvement in informed consent actually enhance individual autonomy? So this is kind of how I thought of this research. to try to identify ways to enhance the informed consent process for HIV interventions that have direct implications for participants and their sexual partners. Again, here on the left, we have the status quo where we have minimal relational considerations. There's individual agents in their own bubbles, nobody thinking about anybody else when they make decisions. Swinging to the right-hand side where we have third-party consent, where a partner would have to provide consent, which obviously we don't want. But again, what falls in the middle? Because those are only two extremes. So now I'll get into my MRP, which was couples' perspectives on research participation involving dyadic-based HIV prevention and care in Tanzania. So in case anybody needs a refresher on geography, Tanzania is in East Africa. This research took place in a peri-urban area called Kisarawe, about an hour from the administrative capital of Dar es Salaam. And here's just some pictures to give you some context. In the middle is the marker. On the far left-hand side is a community meeting where we're doing sensitization about a study. On the bottom left is the hospital. On the far right is my cab. And interestingly, I was thinking of this as Celia was speaking. So my MRP was on serodiscordant couples in Kisarawe. This is a small place. It wasn't like serodiscordant couples are advertising themselves and walking around wanting to be on my cab. I needed those serodiscordant couples as potential participants. So I was stuck. I needed a cab, but the only way to get one without taking from my participant pool was to find a proxy. And so what I ended up using, these are all data collectors from the parent study. They had spent months and months enrolling about 400 couples in this town in the parent study. So they had a wealth of experience interacting with couples, identifying serodiscordant couples. And so this was the closest I could get. And it was really helpful, and they really advocated for members of serodiscordant couples having seen interactions firsthand. So it wasn't the best, but it was next to the best that it could be, and it was really, really helpful. So this was the parent study. It was called Wenzahuru in Swahili, kind of means living freely together. It was a prospective observational cohort study. So there were two sections to it. The first, we did self-testing offered to 440 couples in Kisarawe. Data collectors just systematically went door to door. When they found a couple who was willing, they would offer self-test kits to both members of the couple. They would come back about 2 weeks later to see if the self-test kits were used and offer confirmatory testing right there. Then, among those who were identified as serodiscordant couple, we looked at dyadic-based entry into prevention and treatment for about 60 couples. And within this part of the study, couples were offered PrEP for the HIV negative partner and ART for the HIV positive partner. At the time, ART was available for everybody living with HIV. PrEP was not yet, so it was only available through our study. So my MRP objectives were to understand decision-making and dyadic level influence among members of serodiscordant couples based on participation in the dyadic-based research study and utilization of PrEP and ART. And I'm going to pause here because you all are probably wondering whether you're doing empirical ethics research or something else, something in the middle. It gets confusing. I would say that the door is wide open to what you make of this, but with the help of Lloyd and Celia, these two objectives were very helpful to me because the first was very ethics centered. It was about participation in the research itself and how couples navigated this. The second aim was more study related and more broad that perhaps I could use for as like preliminary. It accomplished both in the end. That is definitely not how it started out, but it became that and it was very helpful. So this was a qualitative study. We did in-depth interviews with members of serodiscordant couples who chose to join the study. That was with 22 individuals. And then we also did interviews with members of serodiscordant couples who chose not to join the study. There was less of these because they were just harder to identify, but we did find some. We did coding and synthesis by both cultural insiders and outsiders. Essentially, we had a team in Tanzania who would read through the Swahili transcripts, a team in the US who would read through the English transcripts, and come together to make sure that we're not missing cultural nuances. And some CAB members did participate in data analysis, which was very helpful in these techniques from the constant comparing method for analysis. So these are just some examples of the interview questions that we asked. So we looked at relational influence leading up to and upon revelation of serodiscordance. And we looked at study specifics. What were the individual and couple level perceptions of benefits and risks to this study? Looked at perceptions of autonomy for the study participation. Did they feel that they could make an autonomous decision? And barriers and facilitators to self-testing and PrEP and our use at the couple and individual level. Sorry, too many things here. I might need your help. Yeah. How do I go backwards? Should. Wait, we did it.
Yep.
Okay, we're good. Okay, thank you. Okay. So what we found from the parent study, so we did offer the self-testing to 440 couples. We found 31 positive individuals. It's translated to about a 3.5% prevalence, which at the time was actually pretty reflective of the national prevalence. We did find some individuals who already knew they were positive, so they chose not to participate. Among these, we found 19 serodiscordant couples. I think this is important to highlight because to Adrian's point yesterday of using like your partner status as a proxy. So we found 6 couples that were seroconcordant, so both members were positive, and 19 where they had different sexes. So the majority were serodiscordant. Of those, 10 couples or 53% enrolled in the second portion of the study, the dietic care portion. We did enroll 62 couples overall. The vast majority were recruited through the existing care and treatment center. So essentially couples where the positive partner already knew their status and were already in care, but they had a negative partner. And this graph just shows like how many couples we found over time. And the blue is like how many agreed to participate. Or no, sorry, the blue is how many were identified and the green is how many enrolled. We do see this slight uptick towards the end. Community acceptance of the study was pretty high throughout, but I do kind of wonder if as the community got used to seeing us every day and that people were reflecting back on their experiences, I do wonder if that kind of helped with uptake towards the end. So what did we find? So lots of interesting findings for recruitment. We found that couples either learned of the study together or separately. We had assumed, or I had assumed, that we would come to the door, both members of the couple would be there, we would talk to them. It's like the ideal scenario. That rarely happened. Most of the time, one person was home, and so then it kind of became their responsibility to tell the partner about the study. And we realized that this gatekeeper partner was really important. That if they were enthusiastic and wanted to do it, they it became kind of, they were the salesperson for their partner. If they weren't interested, then that was the end of it. So very important to provide that partner with information that they could then provide to their partner. Informed consent, again, ideally in my mind, I thought we would, get to the point of informed consent and participants would have, no idea what the study was about and we would give them all of this information. When in reality, couples had known and made up their mind long before they got to that point. They had been to the sensitization meetings in the community. They'd seen their neighbors have the data collectors visit them. They knew what the study was about, and they had made up their minds long before we got to this point. We also put so much time and effort into thinking how to do this ethically, because both members of the couple had to agree to participate to be in the study. What we did is the data collectors would introduce the study when they had both partners together, read through the informed consent form, then partners would be left alone to talk about it amongst themselves. Then data collectors would separate them to make the actual yes or no, I want to participate. And if a partner said, actually, no, I don't want to do this, they were then brought back together. And at that point, we would say, thanks so much for your time. It turns out, you're not eligible. Okay. If they both said, yes, I want to do this, they signed, and then brought back together to complete enrollment. For enrollment, this is just something that's hard to avoid. People really saw this as a service being provided and not so much as research. And that point was hard to convey. I think this is especially true in resource constrained settings where people don't have a lot of access to healthcare. And here you are showing up at their door, offering them PrEP, offering them facilitated, HIV testing and introduction to ART. Like it became in participants' mind, like this is a service and I want to be involved. It's just kind of a reality. And then for the use of PrEP and ART, we found that couples found both perceived individual and partner benefits, and it kind of helped their partnership as a whole. Some other like critical themes that we found was this idea of partner support and altruism. Once HIV was disclosed within a relationship, it was not widely disclosed. So it became like the shared secret within the couple. And then negative partner became this really important source of support for the positive partner. This idea of prevention altruism kind of worked both ways. So the positive person would want to be on treatment to protect their partner, and the negative person would want to be on prevention to help protect themselves. And so here's like an HIV positive man. I decided to join the study because I thought in this study they will help me not to infect my family. So clearly this relational idea is there. There was also, we found a role of HIV and gender in decision making. There's a quote from an HIV positive woman explaining that she herself, she was not able to start this conversation with her partner. But luckily after those research people came and talked to us, it made my husband start the conversation in the evening. So it really, the research itself facilitated this conversation among couples, which was an unexpected finding and an important one, because I feel like it's often missed when we report out on these things, that the research itself almost acted as an intervention. And I feel like that's just not reported on much. And then finally, just this relational benefits of PrEP. There was really quotes that made me very excited and sad at the same time. I see these medicines as the ones to save my marriage. And the issue with this study and with some post-trial access issues is once PrEP was gone, there was a gap between the time when the study ended and when the national government kind of rolled out PrEP. So people lost access to PrEP for a while. And there were quotes in there that was like, if PrEP wasn't here, like I'd leave my partner. So like heavy. MRP was published thanks to RETI for the encouragement and the push. And so some implications that that I've taken away from this experience is that if a study impacts a couple or a family, which honestly, like a lot of research does, even if you're not involving a couple in particular, allow time and space for information sharing and joint decision making. And failing to allow for this can bias results. And so like, here's an example that I was working on another study right at the time when I was writing up the MRP. And this was a study where we were systematically interviewing people living with HIV in a clinic. And during the survey, asking them, would you be interested in participating in the second component? That's like a family-based intervention for comorbidities. So like if we found somebody who was hypertensive or diabetic, offering to like come to their house and educate family members and to test for comorbidities and nothing about HIV. So like most HIV treatment programs in sub-Saharan Africa, most clients were women, 70%, 30% were men. But when we looked at who said yes to that second part about family-based, we see that 30% of women said yes and 70% of men enrolled. So we had this skewed second part of the sample, and I can just envision like people being asked that question, would you be willing for us to come to your house? And men who are like head of households are like, sure. And women are like without having that time and space to ask their partner, we're probably like, no, like if you're making the answer on the spot, like, but so this was said and done by the time there's no going back, but like in the future, I would not do this again. I would make sure to allow for that time and space and not people like give an answer on the spot. And so I'm like enrolling participants right now in a study for PrEP involving adolescent girls and young women. And it's the same kind of clinic-based recruitment, but we have made it clear to data collectors that if a participant says no, or I need to go home to talk to my partner, they're given materials and allowed to come back whenever they're ready to participate. So this is like carried through, I feel like, in my current research projects. And this is the same the same idea that, so we have, again, this kind of status quo of you don't think about anybody else when you're doing informed consent versus the third party consent. And where I think we can really help build this middle is to facilitate information sharing. So provide materials that participants can take to partners, take to whoever in their lives influences their decisions. If you are doing couple-based or any kind of dyadic-based research, maybe meeting individually with one partner before talking to both might be helpful. It totally depends on the context, but allowing for both, either kind of they learn about it together, or if one's really interested, making sure that partner has the ability to convey the necessary information to their partner. And then there's just this third point that couples might really welcome research staff as conversation facilitators. Surprising finding, but they really filled this critical role. Well, couples felt that on their own, they weren't able to talk about this. But when all of a sudden, a respectful, caring researcher comes into the situation, they're like, oh, this provides an avenue and space for us to talk about this.
Sorry.
Yeah, no,
Did that happen a lot, and was it gendered?
Yes, it was gendered. Primarily, it was when a woman was living with HIV. She felt unable to talk to her partner about it, about what he could do to prevent HIV because he didn't like using condoms. And so like there was this one interview where it was like, the HIV positive woman's like, I knew about the study, and that night for dinner, I made my husband green bananas. And I told him how much I loved him. And then I showed him the research material, and then we joined the study. So like, it was definitely gendered. But also men too, like they couldn't talk about it. And so like it was more gendered, but like it applied to both. They needed a third party to like open the door to be that conversation starter. Oh.
All right, so this presentation is going to be both on some of the challenges of getting a waiver of informed consent for research involving adolescents, especially adolescent males who have sex with males for PrEP studies, and then the components of competence to consent, which is the MacArthur CR evaluations and the different levels of consent understanding, and then how to measure that. So that's what this is, and it's just some studies that we've done. So what are the informed consent challenges for adolescent males who have sex with males? Well, that's anybody under 18. We want to respect youth's developing autonomy, but we also want to protect them from research harms arising from a lack of consent understanding. So it's kind of two kind of conflicting approaches that we need to take. But we also need to critically evaluate whether IRB risk-averse approaches to these mature minor laws, which I'll talk about a little later, are placing an undue research burden on AMSM to obtain guardian permission. And at the same time, we have to determine whether overestimation of youth consent vulnerabilities are depriving them of participation in research that's essential to developing health appropriate health services. So that was our guiding aims. So vulnerability in research regulations. So you're allowed to waive guardian permission under federal regulations if the research involves no more than minimal risk, could not be practically carried out without the waiver, and that the waiver would not adversely affect the participants' rights and welfare. The problem is that a lot of IRBs just ignore this, and they go to subpart D, and they don't even go back to this. Especially for minimal risk research. And here, based on what David was saying, one of the issues is that if you're waiving guardian permission under this minimal risk statute, one of the things is, how do you determine that it's not going to adversely affect the participants' rights and welfare? Well, one is to assess or have research that lets you know, that has already documented that they can understand the informed consent for the type of study that you're doing. The second is to have supportive decision-making, which is, one way, and that what we've called a participant advocate, right? Who discusses the study with the adolescent independent of the researcher. So to protect those rights. So there are multiple ways to ensure that the waiver does not adversely affect the participants' rights. And I'll get to not practically carried out in a minute. So one of the problems is that also under the common rule subpart A, when they talk about vulnerable populations, one of the examples is children, right? So IRBs get very, oh my God, we have to protect children. And so that the statute says requires additional safeguards to ensure selection of subjects is equitable and that they're not subject to coercion. So it's another reason why they're not paying attention to the other regulation. Then to protect vulnerable children, OHRP and FDA and their subpart Ds require guardian permission, which is a good protection. There's nothing wrong with that if it's needed and it's not going to harm the participant. And so they have two exceptions. So one of them is when guardian permission is not a reasonable protection. So guardian permission can be waived when it's not a reasonable protection to protect the subjects. The problem is the only example they give is neglected or abused children. So IRB say, well, if you're not neglected or abused, we're not going to waive the guardian permission. However, there's sufficient data on LGBT youth that if in fact they're outed to their parents, and they're not out already, but they're outed because you're asking for guardian permission, they've been kicked out of their homes, they've been punished, they've, been ostracized and stigmatized. So, guardian permission is actually not a reasonable requirement for a percentage of LGBT children. So in addition, parental permission is not required for mature minors. If you look at the federal regulations, they define if you're a mature minor, you are not a child and you do not come under subpart D. So you're an adult. So under federal regulations, minors are classified as adults if they've attained their state-defined legal age for consent to treatment or procedures involved in a research study, right? So if in fact, minors are allowed to get abortion at 16, well, if you're doing a study on abortion, that's a minimal risk study, for example, or even if it's not, then they are adults in the eyes of their particular state. Now, the problem is state laws vary. But if somebody's allowed to get substance use treatment by the time they're 14 in a particular state, then they're a mature minor and they shouldn't come under subpart D for that particular study, if that's what it's about. But the IRBs are very reluctant. And as they become more tied to the legal offices in their institutions, the legal offices are reading mature minor laws, and some of them, in our experiences, have said, well, they don't say research in the mature minor laws, so we're not going to do it. And that's really harmful to these populations.
So who defines the mature minor in the end?
Well, the state laws don't say, they don't have anything about research in it. They're just defining mature minor as somebody who's allowed to get these kinds of services. But under federal regulations, if you're allowed to get these services at a particular age, you are a mature minor and you don't come under subpart D. Right. But the IRBs are totally ignoring that. All right. So the failure to distinguish between HIV. Oh, so this is the other thing, that adolescence does not necessarily, and LGBT adolescents or marginalized groups or people who are at HIV risk, just because they're at risk and they're vulnerable in their daily lives, does not mean they have consent vulnerabilities. And we tend, so a lot of times, IRBs will be very, very concerned. And in some instances, they should be, for example, in interpersonal violence research. I mean, that's something they need to be, because if the abusing spouse or partner learns about the study, that could be very dangerous. So, there are situations in which it's very important to consider the vulnerability that is related to the actual consent process. But just because you're at HIV risk doesn't mean you're at risk for giving informed consent. And so adolescence is not necessarily equal consent vulnerability. And the problem is if we really can under or overestimate the ability of youth to give informed consent. And so I'm not advocating that we just, when we waive consent, we decide that all these youth are capable, because as I was saying to Pablo, that one thing is to have the social cognitive ability to understand what you're saying. The other is the experience of life, to understand what that means. So, and you'll see that that's what appreciation is in these kind of MAC things, so.
My kid's destroyer.
So, I don't know, I like this picture about getting informed. Okay, so, so without youth involvement in research, and it's interesting, because Pablo was saying in the ATN that he's working on, they just don't do it if the IRBs are not allowing waiver of guardian consent for 15, 16, 17-year-olds and it's a behavioral health study. So it's, I would say it's minimal risk, but it really depends. And many of them may be mature minors because they're allowed to get psychological services without consent. So it's interesting. So, but evidence-based developmentally appropriate HIV interventions will continue to be unavailable for AMSM. And even if they're available, they're based, you can't just extrapolate data from adult studies to sufficiently address the developmental need challenges for medication uptake or adherence for adolescents. So here's a study that we did to evaluate their competence to consent to an oral and injectable PrEP RCT. And as you know, so before I get to the actual study, I wanted to go to the elements of informed consent. Applebaum and Grisser first looked at this in terms of consent for treatment, in terms of psycho-legal stages or levels of consent, which was very important in terms of when would somebody with schizophrenia, for example, be judged as not competent to consent from a legal perspective. So the first level, which I don't have here, is choice, right? Can they even say yes or no? Obviously, adolescents can do that. So understanding is the first level. Can they spit back to you what you just told them? If you're in a PrEP study, you're gonna have to take, a pill every day, or you're gonna get an injection. Can they tell you that? Do they understand what you said and what's in the information? The next level is appreciation. Do they have an understanding of how participation in this study is actually going to affect them? Can they take a pill once a day? Other studies, I don't think I have the data here, but other studies we've done on that, we have people who say, well, I take birth control pills every day, so I can certainly take this pill. But we have other people who say, I'm very forgetful, so I don't think I can be in a PrEP study. So, that's an example of appreciation of what it means. Some people say, I can't get here. I don't have a car. This is an adolescent. I don't have a car, or, I'm not telling my parents I'm in this, so I can't get here. That's an appreciation of what the study means. You'll see another example where, there's a minimal risk of PrEP to have some kind of bone problem, which can be easily remediated. But, if that's a concern for somebody, then that's an appreciation. That's really a good. And then there's also reasoning, right? So the last level is, can they reason? And so there's two different types of reasoning. One is, can they compare the risks and benefits of being in this study to make an informed decision for them? Because remember, the IRBs have already decided that the risks outweigh the benefits, that risks have been appropriately minimized, that benefits have been appropriately maximized. So from the IRB perspective and the research perspective, this is a study that is ethical from a risk-benefit perspective, and that's good. But that doesn't mean for an individual person, the risks and benefits are good. So that's why individual choice is so important, because they have to evaluate that in terms of themselves. And then there's consequential reason. Whether or not is the decision consistent with their anticipated regret or anxiety or satisfaction with their research experience. So there's two ways of looking at reasoning. When you weigh risks and benefits, and how are you anticipating you're actually going to be affected emotionally by this experience? So those are the kinds of things we're going to ask. So the MCAT is useful, but it's also requires a lot of independent work of any researcher who's doing the study, because everything is context specific. So you have to develop your own criteria for whether or not they understand your specific study. In addition, they do not give you any absolute threshold for what is consent, because they say it is relative to a norm. But who's the norm? That's the problem, right? So maybe in schizophrenia, the norm is somebody who doesn't have schizophrenia. But what is the norm for adolescents, right? In terms of competence to consent. And typically the norm in these studies are just applied by the research team. They just decide what is going to be the norm, okay, in terms of how many questions are you going to get correct. So we wanted to do something that's a little more empirically guided. In this present study, we assessed the competence of 14 to 17-year-olds to consent, and we decided that the empirical norm established would be 18 and 19-year-olds who are considered adults under any law. So if you're going to not let a 17-year-old consent, but let an 18-year-old consent, you have to figure out why, okay? As I said, that this is why the norm was selected. Okay, this was a very complicated study. We took this from the current PrEP pills versus CAB new injectable injections that were going on at the time. So the purpose of the study, right, was to compare the pills to the injectables. You had to be HIV negative, so you had to take an HIV test. And you had to be at high risk at using unprotected sex. In addition, the pre-trial procedures were pretty complicated. They lasted for 5 weeks. You had to continually be HIV tested, but you also had to take the CAB pills. It's almost like a phase 1 trial to determine that they were safe for you. Okay. Then the procedure was also quite complicated because it was a within the subject's randomized trial. So you take the pills, the PrEP pills, then you take the CAB, then you take them together, and it was all quite complicated. And then, you know, there were the side effects, which was, you know, quite a mild headache, upset stomach, but there was these rare reversible side effects of PrEP, which is reduced bone density and kidney health. Once again, which is reversible as soon as the doctors would test it, and you had to keep going for testing. Then what are the services you would be getting? During this period, you'd be getting HIV testing, you'd be getting monitoring, you'd be getting counseling, you'd be getting all these kinds of things. And then, you know, the IRB was there for the protection of your rights. If there was a violation or concerns, you could contact them. We also included the whole thing about personal insurance that hospitals, you know, some of the IRBs require. We're not going to cover you, you know, so we wanted to do that. I don't think I'm going to talk about that, but had that data. Okay, so it's a pretty complicated study. So what we did was so I had been looking for years how to figure out, because I was really concerned that if you just do average mean testing, you know, are the kids answering the same amount of questions as the 18 and 19-year-olds? That doesn't tell us if they're competent to consent. We don't know. The 18-year-olds may not be competent to consent for all we know. So I finally was able to, we have a really good psychometrics program at Fordham. So I was talking to one of my colleagues, Leah Fernstein, who's an author on this study. And so there's something called cognitive diagnostic models, which can actually tell you the proportion of examinees at a criteria who are actually understanding something. It's quite complicated, and all these graphs and all these kinds of things, which I still don't understand. So I was really glad that she was there, you know, and The first thing we did was, I understand this part. We did a factor analysis to determine that our informed consent questions were actually, different from appreciation, because I think that's really hard to figure out. But we did find that they were, and each had 7 items. So that was really important, because it's kind of tough. You're taking a pill, but how will the pill affect, do you want to take a pill? So that was hard. So what we found was that in terms of understanding and appreciation, 82% of 14 and 15-year-olds, 100% of 15 and 17-year-olds, and 99% of 18 and 19-year-olds understood this, okay? These 2 things. And only 2% of 14 to 15-year-olds were estimated to not be able to understand or appreciate. So even though it's only 82, even though it's 82, that's still a lot. That's what I loved about this. This was telling us what percentage actually understood, and not just differences in mean scores. So what we found was there just was really no differences in understanding and appreciation. These were all the questions that we asked about random assignment, participant responsibilities, withdrawal of HIV. Really complicated questions. The exceptions were that the therapeutic misconception still existed more in 14 and 15-year-olds, but it's still only 76%. And 85% in 16 and 17-year-olds. So therapeutic misconception was that they thought they were going to be put in the group that was best for them, that the random assignment was really not random, that they were put in the group that the doctor thought was best for them, right? But the beauty of this is that when you find what young kids don't understand, it just means you improve your informed consent. You don't not include them in a study or not waive guardian permission because of that. But remember, I was talking about goodness of fit. Is the onus is on us to make sure that our informed consent or our procedures are fitted to what they need. So it's not bad to find that adolescents are a little confused about something. It just means we improve our informed consent for them. Okay, so then in terms of can they make, the next level is the reasoned decision. And so the majority, so as I was telling you, whenever you do these hypothetical studies, you find the majority say they agree. And that means nothing really, because you don't know what they're going to do in a real world space. So I don't pay as much attention to it, except whether or not it's correlated with how they actually comparatively reason and consequential thinking. So this is so interesting. So, here you have this MCAT-CR, and we're all saying that, in order to reason, you have to compare risks and benefits, but most of us don't. Like if you need a tooth extraction, you must say, no, I'm not doing that because I don't want to go to the doctor. You don't weigh the risks and benefits, right? It's not really, some of us do, but a lot of us don't, and we're adults, but that's not how we make decisions a lot of times. We just say, wow, that's good for us, so I'm going to do it. And that's why we have the RBs there. That's the positive, the positives. I just annoyed at waiver of guardian permission. But on the very positive side, that's why the IRBs are there, to make sure that this is an ethical study that has minimized risks and maximized benefits. But that doesn't mean that's how people actually make decisions. So 52%, only half of those who are considered adults report back to us that they're weighing risks and benefits. But all of them, 73%, talk about benefits and risks in their reasoning, because that's how they're doing it. But they don't say, I'm going to do this because of this, right? So I think we have to be very careful about a philosophical idea about what reasoning means if we're going to use that as a limit for anybody, not only adolescents, but adults with intellectual disabilities to agree to participate in the study. And so if you look at this, there's no difference in percent of reasoning ability. So applying a normative, MAC criteria, adolescents are just as good as adults in terms of reasoning. Okay, so then in terms of, here's some examples of their balancing risks and benefits. These are the benefit of finding out and what form of PrEP is good for me, and learning how it affects the teenage population outweighs the risks of side effects, right? So that would be somebody who's actually telling you about risks and benefits. This one doesn't want to be in the study. I don't believe that I'm at much risk of getting HIV, and I don't want to inconvenience myself to make these clinic visits. I understand the benefit of free HIV drugs, but I'm also concerned about their long-term side effects because they are relatively new. This is great. This is such a good reason not to participate in the study. So remember, if you don't get a percentages of no, something is wrong. Okay. And here's non-comparative reasons for, I just, as a closeted gay boy, I've not really been told or shown the best protective measures to take for preventing HIV. So doing this. So they're talking about the secondary benefits. And as Ginny was talking about, I've always thought good research is intervention because it's always educative or empowering to marginalized populations when you do it right. Here's another one, free access, right? Participating in the study will offer me access to a wide range of resources that I typically can't get. A lot of people, it was so funny. A lot of them was free condoms, free condoms. That's why I'm going to be in the study. I'm going to get free condoms. And altruism. I don't know if you found this, but in our studies, and John may have found this, but so many kids say, I want to be in the study because I want to help other people like me. And thank you for doing this because most people don't care about us. No, and that's transgender youth as well that we've worked with. And side effects, like they don't want to disrupt their daily life, or they're afraid about the bone deficiency, even though they know that it's rare, they don't want to get headaches. Great reason not to participate. And then confidentiality and stigma, of course, that's always a concern, but I wanted to get these here for youth. This is, it also speaks to how afraid they are about guardian permission, because even if they waive guardian permission, if I got side effects, my parents would know. So then they'd know I'm in the study. Or, and this is true, this is, I think it relates to something Ginny was saying about why you're taking PrEP. But here, as some of you know, even within the LGBT community now, there's some of a stigma about taking PrEP because it may mean that you're, promiscuous. So, this is something that we're seeing a little bit more. And that's a sad reason not to participate. Okay, so just in summary, the value of empirically informed consent procedures, and like I was saying, the kind of research that you do, about informed consent or anything can be used to really bring to. So you should, really be familiar with the research out there, all of the research that our fellows have done, because you can bring that to the IRB to talk about how you're following these things in terms of risk. Also, the CAB is very helpful. Because ask the CAB, what do you think the risks are? What do you think the benefits are? Have I sufficiently minimized? What would you suggest? And take that to the IRB, because then, IRBs work in a vacuum, right? They can only guess what is going, unless, they've done these studies over and over again, but otherwise they're just trying to guess what's going to be helpful and not. And so for you to be presenting other people's data or what the CAB says is going to help the IRB make an informed decision. Okay, so using empirically informed procedures that are relevant to the particular study. As I said, data on consent misunderstandings isn't bad, it's good. It helps us improve our informed consent. Also, this was a suggestion by one of our youth to tell us in your informed consent procedures, how we say these are the risks and benefits, but you could also say, this is what people like you have said are the risks and benefits of this study. And this is a much more interesting way to talk about risks and benefits for them. And so I think to help IRBs, protect the rights and welfare of sexual and gender minority youth, or any any youth who were asking sexual questions because they, or drug use questions. We need to reconceptualize access to HIV prevention trials as a critical healthcare right. And I think we don't do that enough, and that it requires protection against research exclusion. And I think we have to think about that and talk to IRBs and talk to federal regulators, that's how we have to begin to look at this kind of research, continuing with all the protections that we need, but recognizing that an overestimation of risk is actually a danger to these kids.